Greetings to everyone watching this video. Myself Abhinav Santosh, a student at Mawadi University, SYBPT, and my topic is pneumonia from pathology. Pathophysiology and defense of pneumonia. Pneumonia represents an acute inflammation of the lung parenchymal cells, impairing terminal gas exchange structures. Etiopathogenesis caused by alveolar invasion of pathogens via microaspiration. Defensive breach occurs when coughing reflexes, nasal clearance, or mucociliary clearance mechanisms are compromised. Exudation response. Capillary hyperpermeability floods alveoli with protein-rich fluid, impairing oxygen diffusion. The four pathological stages. Day 1 congestion, day 2 and 4 red hepatization, day 4 to 8 grey hepatization, and day 8 and above resolution. Stage 1 stage of congestion. Pathological morphology. Gross appearance. Lungs appear heavy, boggy and dusky red, squeezing, release blood stains from the fluid. Microscopic. Severe vascular congestion, dilated alveolar capillaries, intra-alveolar bacteria and few neutrophils. Clinical signs. Systemic signs. Sudden onset of pyrexia, rigors, systemic malaise and heavy breathing. Auscultation. Decreased breath sounds and isolated fine inspiratory crackles as initial fluid starts to collect. Stage 2 red hepatization. Alveolar consolidation. Morphology. Lungs become dry, completely consolidated, airless and firm, resembling a liver. Capillaries remain highly congested. Clinical features. Patients present with heavy chest pain, high fever, dyspnea and a cough yielding typical rust-colored sputum. Stage 3 grey hepatization. Fibrinopurulent solidification. Pathogen. Red blood cell actively disintegrate, leaving behind thick networks of fibrin and abundant neutrophils. Lung transition to a grey-brown, dry and dense consistency. Ischial nature. The immense accumulation of fibrin plugs inside the alveoli compresses adjacent alveolar capillaries, creating a localized ischemic zone. Clinical impairment. Alveolar aeration is entirely compromised. Local ventilation perfusion ratio V by Q drops to 0, predisposing severe localized shunt and hypoxemia. Day 4 resolution phase. Enzymatic breakdown. Proteolytic enzymes released by decomposing neutrophils liquefies consolidated intraalveolar fibrinopurulent plugs. Macrophage dominance. Alveolar macrophages become the dominant immune cell, engulfing cellular debris, bacteria and digested fibrin. Structural recovery. Liquefied material is either reabsorbed into regional lymphatics or coughed up. Alveoli re-aerate, restoring architecture with no scar. Rehabilitation objectives. Secretion clearance, alveolar recruitment and physical mobility. Airway clearance and drainage. During the resolution phase, liquefying secretions can accumulate in lower airways. Rehabilitation aids clearance. Postural drainage. Positioning patients so that gravity helps drain secretions from specific lung segments into central bronchi. Manual chest therapy. Percussions and mechanical vibrations shake lung walls to lose thick mucus. Huffs and controlled coughs. Active respiratory cycle exercises move secretions up into collapsing floppy airways. Breathing and spirometry. Sustained lung expansion. In situ spirometry employs slow, deep inhalation maneuvers to establish visual flow feedbacks, improving vital lung capacities. Diaphragmatic re-education shifts focus back to lower coastal chest movements to optimize diaphragmatic excursion and reduce hyperventilation. Pursed lip breathing maintains positive back pressure inside smaller bronchioles, preventing exhalation airway collapse. The following chart explains the rehab impact of recovery. Thank you and have a nice day.